Tom, it's important for us because the oncology world talks about predicting outcomes with biomarkers. We have trials in the frontline setting that were comparative trials, ComPAR's trial, for example. So when you have two TKIs that have been shown to be commercially available with comparable levels of activity, possibly a different toxicity profile, how do you think about that when you approach the patient, and what does that discussion sound like?
Yeah, that's a very good and meaningful question. I think, just take a step back as we're unlaying this, what are goals of therapy for the patient. I want to give my patient and their family a sense of what the natural history of the disease is going to be like, in that we do have now 9 therapies at our disposal to utilize, and patients often have come in because of media with thinking they're going to get XYZ therapy first, and understanding that our goal, as Dan and others have suggested, is that we want to maximize the benefit on the current therapy. They will get these other therapies in due time sequentially along the way. And so what we try to bring to bear is evidence-based medicine. And as you've alluded to, the fact that so we've got standard options that we consider to be really global standards of care in the frontline setting, with most patients receiving one of 2 VEGF TKIs, sunitinib, pazopanib. And up until 2 or 3 years ago, we didn't have any trial that compared the two, but we're fortunate now that we have a trial, the COMPARES trial, which was designed not as a true head-to-head comparison, but a non-inferiority study. But we have now a trial with almost 1,200 patients in it, which gives us some idea of the nuances between the agents. And from that trial, we know that both agents seem to be similar in efficacy and outcome. Slight nuances there. Toxicity is shades of gray, difference between the two, and really enough that when I've interacted with community oncologists, they haven't been swayed one way or the other based on toxicity for it. So what we've been really trying to instill upon the community oncologists is that get familiar with the drug, one of them. There are 2 here that are equally efficacious or similar in efficacy. Know how to use that well in your patient. So if that is sunitinib, know that you can do dose modifications and how they work, how to manage toxicity. Know about the 2-1 alternative dosing schedule with that. If it's Votrient, know about that drug and the need to monitoring liver function tests. And I think, at the end of the day, as long as the patient has had either one of those therapies and they've been delivered well by the treating doctor, managed well with toxicity control, then I think we've done justice to our patients for that. Now, your other question was, as a field, are we at a point where we can start picking and choosing between one drug or another based upon biomarkers or take another step into patient or tumor characteristics? And the answer is no, but we have certainly identified a phenotype of patient that we think does well with VEGF inhibitors. We haven't really been able to connect the dots between that and a biomarker test. And I'm encouraged by what we're seeing at meetings like ASCO about, for instance, mTOR inhibitors, about finding different mutations in PTEN and others that predict that group of drugs may work better in a patient population. The interesting thing that we've had with VEGF inhibitors, to be honest with you, is they work in 80% of our people. So, we know that hypertension may development of that on therapy predicts response to therapy, that they're going to do better when they have that or other side effects, but most of them will have that because it works in most patients. So what we really want is to be able to get that blood test, that simple blood test, or be able to look at the tumor specimen and be able to predict that way, and we're just not quite there yet.
So Nizar, Tom brought up changing dose and schedule. A couple of years ago, we didn't have that option. When we were using sunitinib, it was the 4-2 schedule because that's what we had. That was what the package insert said. We now have some retrospective studies that have suggested that you can maintain dose area under the curve with a different schedule. How do you incorporate that into your practice when choosing drugs?
Yeah, I think this is an important area because I think the goal is to keep the patient on therapy as long as possible and not stop therapy and change to a different agent because of toxicity if they are benefiting from the therapy in terms of efficacy. So that's where, at MD Anderson and other investigators at other institutions also, when we looked and we just talking to the patient when they were taking the sunitinib for 4 weeks in a row, their adverse events peaked towards the 3rd, 4th week.
Absolutely.
So it was intuitive to say, well, what about switching to 2 weeks on, 1 week off, and then still in a 6 week block, they're going to get the same number of doses, but can we mitigate the adverse events? And when we started going to the 2-1 schedule, and we published this a couple of years ago in 180 so patients, we saw that patients who received sunitinib with a 2-1 schedule stayed on therapy longer. And there was suggestion that those patients had a better outcome in terms of survival. So obviously this is retrospective data, and all the data published with this, except for one randomized phase 2 trial from Korea, I believe, there is the possibility the patient selection bias. But one trial, as I mentioned, was a randomized phase 2 trial looking at 4-2 versus 2-1 schedule, showed that for adverse events, the 2-1 schedule was better tolerated, less toxicity, but the efficacy endpoints or outcome were similar. So I think, now if we use sunitinib, and I agree with Tom, I think it's more about what you're comfortable with. If you're a community oncologist and you see fewer patients with kidney cancer per year, and you've already been used to treating them with one agent and you're comfortable with that agent, I think that's fine, you can just continue. But now we have an alternative. If you are comfortable with sunitinib because it came out many years prior, then I think the 2-1 schedule does make sense. I have to say, though, we have now at MD Anderson, actually, it's a multi-center trial with Betsy, your group, as participating in a trial, and Cleveland Clinic and other sites, where we're doing single-arm study 2-1 schedule. And when we go to a prospective study, unfortunately, I'm still seeing a lot of hand, foot, and a lot of fatigue, a lot of diarrhea, with myelosuppression, even in the 2-1 schedule. So I am of the position that, and I think there is data to support that from PICES and compares, that in general, pazopanib is better tolerated of the two agents, even, I would say, when you go to the 2-1 schedule. The 2-1 schedule is better tolerated than the 4-2 schedule, but I believe when you look at pazopanib versus sunitinib overall, even if you use the 2-1 schedule, pazopanib, in my opinion, is the better tolerated agent, except for the liver toxicity where you have to be careful. But I think, we need to move beyond. I think the field is shifting so fast that I think, sunitinib, pazopanib are probably in the next 2 years not going to be the first-line therapy, which I'm sure you're going to lead us to the next segment of what will be the future. I believe the future is going to be with possibly combining an IO agent such as a PD-1 or a PD-L1 plus a better tolerated VEGF-directed therapy such as axitinib or bevacizumab. So I think that's where probably the future, obviously no data yet for the practicing oncologist, but I think this is where the future is going.